the time, most of these test kits and things were really expensive, and they were costing the government so much. So that is actually a lot of money, like that is a lot of cost on the government. So these community governance systems really helped to curtail those costs. First of all, they were like gatekeepers. So before you would go, maybe you started having maybe fever. So they were the ones that would check and then ensure referral to maybe the hospitals. And also it also helped to reduce like overcrowding too as well, like at the hospitals at that time, because they were also trying to implement like quarantine measures. And then, just like I said, they had information of like, everyone, let's say in the neighborhood. So they helped to pass information between, the community governance systems and then the high authorities like the Ministry of Health and also all the ministries and, people that were involved at the time. And then they got information and also shared them with the communities too as well. Then, since people were not able to, go out to do groceries and do all of this, so the community governance systems, they were then able to like allot people who helped with providing services support, especially like to the elderly. It was just wonderful, like when I read about it, and it was just just amazing, because to see that the community governance systems, these people were actually part of the communities themselves. And then an outstanding result from this was effective risk communication, because people got to know about COVID-19, got to know how the disease was spread, what they should do to stay safe, and then implementation of quarantine. So even though there were people who maybe were not a part of a particular community governance system, but they still tried to ensure that everyone kept in touch like with the law at the time in China, and then just really helped to reduce the burden of the disease in Wuhan at the time. And then really striking was that COVID-19 was contained in Wuhan and also like in the world as well. So those are just two case studies from the United Kingdom and then from China. And then there's this one which I really love. It was a colleague that shared this in a course we were doing on health governance, but I'll just focus on basically just on a key point here. So at the time in Finland, just after World War II, infectious disease was on the rise. And then not just infectious disease, at the time too as well, NCDs, were also coming like to the limelight, like cardiovascular diseases, stroke, and the likes. And then but this now involved a top-down and a down-top approach, because it was initiated at the national level, where they tried to implement strategies to ensure that these things, the levels of these diseases went down. Let's say the prevalence and the incidence of this disease went down. And then there's this particular village which is used like a very wonderful case. And I was just wild like when I saw the case. It's called North Karelia. So it just involved just ensuring that health was a priority, like across like different sectors. So basically, the people at the time in North Karelia were producing like a lot of agricultural subsidies, like food products which actually had like high fat content, like milk. And something that the government did at the time was, when they involved these people, and then we know too well that these were like these were the means of livelihood, right, like of the people. So what do we do? How do we ensure that they still had something else doing, but it wasn't producing, it wasn't about producing high fat content. So when they engage with the community, because this is actually where community engagement is just so important. So because if you just say, oh, you just have to stop people from like the farmers at the time, like, oh, stop them from okay, tell them, oh, no longer produce milk, or no longer produce taste that had this fat content, how would they survive? So but with the community engagement, they were able to, one, so they stopped them from using this fat content, but they then provided another means of livelihood for them, so which was promoting domestic berry and vegetable products. So they had to change their line of occupation. It was just wow. Like I was just wowed, like when I looked at this case. So from being a farmer, but then now, so they didn't have to change. Okay, or this is not working, and then the communities could also see, because the rates, of these diseases were also really high, at the time. So, and just the government, coming to, at every community and village level, so they could see that, the government were willing to change this, and then the community also were also willing. So it built trust, and then they were also able to trust that, okay, if you take this means of livelihood, you're going to give us a better option. So then that was when the berry project, came up, and then so a lot of farmers then, they had to then change their occupation, certainly what they were producing, to producing berries, which were more nutritious, much more healthier, and then also vegetables as well. And then so I would just like to just talk about like the number three, which is organization of cholesterol lowering competitions between villages. So here at this level, so every community, so it this was now much more community empowered now. So the communities were so engaged, because okay, they've built this level of trust with the government, and then okay, they can trust the government enough to do this, and then they also saw that it was a problem, to reduce the rate of heart diseases at the time. So with that level of engagement, the communities were then empowered, because certainly their means of livelihood were changed, and then they started organizing competitions amongst themselves. I was wowed, like to see, okay, maybe in a particular month, they tested like their like the cholesterol levels, like for instance, and then maybe in 6 months, they then get to like check it again, like for everybody. So it was now like a competition to see like who would have like much more lower cholesterol levels. And you could see that the communities were now empowered to like do these things themselves. They involved NGOs, they involved different community groups. And then one of the major outcomes that came out of this particular engagement was that age standardized mortality rate of ischemic disease decreased by 73%. That's like so much, like never seen. 73% in North Carolina, and then in Finland as a country by 65%. Then also death from cardiovascular diseases also dropped by 75%. That's to show you how far and what community engagement can really produce. I would really encourage everyone to just look out this case. It's a very wonderful case of community engagement. I'll just move quickly to my own personal experiences. So first thing first, I saw this fly anyways. I was just wow. Like when I saw the Equicare strategy share it, it was about an HIV project, right? So like, oh, someone invested like several resources into a project, and then it really didn't yield the fruit, certainly like they didn't have like good outcomes. I'm gonna share an experience from a project I did. I was an M&E assistant on a project called the Lopin 3 project. It was local partners on HIV and AIDS in the south, like the south of Nigeria, south region. So there was a lot of funding, because certainly it was funded by the USAID. We had staffs, we had technical support, we had community case management workers, there was financing. There was provision of ARTs to people living with HIV and AIDS, because basically the project was for orphans and vulnerable children. So children, orphans, or children who had HIV and AIDS, or children who were vulnerable. That's vulnerable in the sense that their parent or maybe their caregiver had HIV and AIDS. So how they could improve so like ensure that these people had better health outcomes, right? So there was provision of ART, there was like collaborations between health facilities and health workers, monitoring the adherence levels, ensuring that, okay, people had ARTs, they had like access to a couple of services. And one of the things that we did at the time, we had so many projects, like so many programs. We had like the Kids Club, we had the Caregivers Forum, and so we had these groups also for like adolescent girls, adolescent boys too as well. And then later on in the project, they then had like this forum for men. It was really wonderful. But one thing that happened, like at the end of the project was that, okay, like during the project was, we noticed that there was low adherence anyways, like to the ARTs. So, we had a lot of like, PLHIVs on the project. PLHIVs now is people living with HIV and AIDS. But then at the end, you're actually giving them the drugs. So, there's all of these things. But at the end, the adherence to these drugs were low. And then with that, the viral load certainly was always going up because it was higher and higher because people were certainly not taking the drugs. And then we just tried to, I think we had just missed the point anyways. But then we then tried to understand, okay, so what was really the case? So people had access to these drugs, like these things were funded, some of them had support, some loans and things like that. But then one thing we then had to, so we then tried to, ask them to understand, like, what was the problem, like what was really happening. So one thing we noticed, because we had like community caseworkers or like community volunteers, and then I think at the point I was also involved with some programs because I also even like went for like some male involvement project. What we noticed, because when we spoke with some PLHIVs, they're like, oh, you have these drugs, yeah, but they're like, why were you not adhering to them? One of them said something that was really striking. She said that even if the disease itself doesn't kill them, that the drugs will kill them. Why? Because the specimen, or maybe like the particular drugs they were taking, where the drugs are very powerful drugs, like so very strong drugs. And so many of these guys didn't even have access to food. So like, you don't have food, you're taking ART, like that, like they'll just rather just like let the disease just rather kill them than for them even taking the ARTs that would even kill them faster. It was funny, but like that feedback really, like it just really shook us. We're like, oh wow. So it was then we then had to, like start thinking around, oh, like how best can we, or what best can we do? So we saw that most of these guys didn't have access, like to food and support like that. So we then had to, okay, then start talking more around, oh, nutrition, or like food fortification. So that was where we then started, talking about, all of those things. And then HIV and AIDS project is also like very complex because having a community of people that have HIV and AIDS, like in there's still a lot of stigma when it comes to this disease. And one of the major problem we faced was that many people, let's say they could enroll in a particular place to take maybe like to be getting like their ART supplies, but then they would rather choose. So if I was like, so they would rather choose to go to another location, like that is not in their own community, to go and take medications there. And you can actually understand with them because the thing like with stigma, which is still big, even though there's a lot of effort still being put in place. And then with that, let's say they were not able to like have access, to go back to that facility. With that, the adherence level is going to go down because they may have not even had time to like, go back for a refill. So, but then when we had to, understand all these technicalities and what was really happening, we then started thinking around, oh, how can we make this better? How can we ensure much more home visits? Now at this time to this place, how can we, give more support? So nutrition came in, some grants, some loans, giving them to these guys. And then there was also something too that we established, which is called Silk Saving and Internal Lending Communities among themselves, which really helped them, to save money and then, have access to like a couple of like funds like that. So with that, it really helped to help them to, like start taking the drugs again, because, and then also it certainly upshooted the adherence, because we know like from the UN-AIDS, there's a target of the 95, 95, 95. So 95 tested, 95 days, and then 95 are actually on the drugs. So we really needed to ensure that all that was happening. But then as M&E people, like monitor and evaluation, we're just only concerned with the numbers. But then looking behind, trying to understand the reason why, like why these people weren't doing that. I think like that was the major thing that we should have really considered. And it was until we started considering that we did not even get the results that we wanted. So we then had to shift our focus a little bit from qualitative data. There's that cult of qualitative data, and then start going toward qualitative. So with that, we got better outcomes, and then so better outcomes like for the people who were on the project at the time. Even till I left, I actually exited the project. Okay, so the second case here is I was working with the County Ministry of Health. at the time, basically in the epidemiology unit. Kano State Ministry of Health is in Nigeria. As you can see, the Nigerian flag is there, proudly Nigerian. The thing I love like so much with Northern Nigeria is like the structures that they have in place. And when it comes to like health, basically, one of the things that I really enjoyed, especially when it came to like integrated disease surveillance and response, was the fact that at every community we had what we called the community focal point. So this is a picture of me in a particular local government. I was so stressed in that local government because we went for to investigate a case of, I can't remember, I think it was like dog bite. Like, yeah, there was so many rampant dog bites in that community. And then here I was with my boss at the time, and he was the state disease surveillance and notification officer. We're together because we went together to this particular local government to do like risk communication anyways here to like, educate the people on, I can't remember the disease it was at the time. So we have community focal point. So these guys are members of the community. And then apart from the community focal point, we have what is called the local government disease surveillance and notification officers. And then these guys are actually members of the community. So they belong to that local government. And then they are, so what then happened is before a disease, maybe there's an outbreak, so the community focal point knew about it. And then they pass the information across to the state disease surveillance and notification officers. There was always that chain of communication. And then since this community focal point where people were members of a particular of the community, so the communities trusted them enough to like, oh, when this was happening, it was reported and then to the local government and then to we who were at the state level. There's also something in Nigeria called the Ward Development Committees, the WDCs, very wonderful structures focused on primary healthcare. So these guys really help like to see, oh, what's really going on at the health facilities. And then they're actually members of the community. So in every community, there's a traditional leader. Maybe there's a traditional leader, there's a religious leader. Those guys are actually members of the WDCs. So it gives them a sense of ownership. And in fact, when it comes to financing of the health facilities, these guys are actually involved. Like I was wild because when I was then working like on health financing, I had to see that even like for some certain reimbursement, they had to sign. Like the WDCs, like a representative of the WDC had to sign for certain things to actually happen. So it showed the level of, like the level to which, the community were, involved, or are still involved anyways. And when it comes to health, and then we had the Emirates Council on Health because Kano State, where I stayed at the time, has like 5 Emirates. They have this Emirates Council on Health, which is like very high level. And then they actually looked out for so just ensuring that people had access to like better health quality. And then every project, every grant, every project, anything that was coming in was always going through these guys because they actually seek to represent the communities or maybe the people under their emirate. And then they knew, part of the problems, the part of so the things that were going in the community, and then they would be able to like, set these priorities for whoever was coming to fund, or even we who at the time were working at the Kano State Ministry of Health. So everything we were doing, we were always working with these guys. And then we had the Kungia Al Umma, some of like the community groups. So for this, so this really helped us like when it came to like risk communication, health education and promotion. So they were involved. And then there's like the Hishba board, like in Kano, and also a couple of like northern states in Nigeria. We worked with these guys, they passed the health information. Most of them were trained, empowered to ensure that they were passing information across to people on, different diseases, how to stay healthy and all of that. So a typical case of that. And then I'm just going to go to the very last experience here from my end. So I worked on the project because at the time I was a monitoring evaluation officer with the Wellbeing Foundation Africa. It was a project funded by the government of Canada and then by Nutrition International. It was a project on scaling up zinc and LORS to improve childhood diarrhea treatment in northern Nigeria. At the time, there was a high prevalence of childhood diarrhea, and then there was also some gaps in the drug revolving fund scheme that was in the state. So what we had to do with the project was, first of all, community engagement. Now, I had previously already worked with the Kano State Ministry of Health, so we just had to just, working with existing structures. Emirate Council on Health, you can see that. You can see the Kungi Al Umma, you can see the World Development Committees. But here now we now had new set of stakeholders, because since we are now working with the DRF fund, with the DRF scheme, we had to involve the Kano State Drug Revolving Fund Committee, then also community health workers, especially community pharmacy. So we wanted to ensure, like, the aim of the project, the WHO and then the UNICEF, recommends that for diarrhea, especially on the 5 diarrhea, that zinc and LORS should be promoted. So we wanted to ensure that these were like first line treatment, because there are, people sometimes could actually resort, to different types of medications, and also with the with this with the rise of antimicrobial resistance, you get. So we just wanted something which was safer, which is like the zinc and LORS. It helps it just helps, for osmolarity. It helps for just ensuring that the child actually stays dehydrated, doesn't lose a lot of electrolyte and all of that. So, and at the time there were some gaps in the DRF scheme, because I think one of the things that happened was that zinc and LORS was not included in the essential drug list, and then some community pharmacists could recommend other drugs, but not necessarily zinc and LORS. So we just wanted to ensure that zinc and LORS was the first point drug that medication that was given to children under 5, first of all, before any other line of treatment came in. So we had to do community engagement, we had to do stakeholder mapping, and then one of the things we had to also focus on was involving guys in the DRF scheme, and then training healthcare workers and also community members. And the community members here was broad, but it was much more focused on mothers, because they were primarily the caregivers of children. So one of the things we did was to develop, and I'm just still so I'm happy for this project, and still thank the Wellbeing Foundation for the platform they gave to me to be a part of this particular project. So I was pretty much involved in developing the standard operating procedures for the DRF scheme. And then we also train healthcare workers on this DRF, on the SOPs, and then also on integrated management of child illnesses, which is very important. Then also we also trained mothers and also help them to, let's say if your child has diarrhea, let's say in the night, in the middle of the night, or maybe you're not able to access the health facility. So what's the first thing you can do? How can you ensure that that child is stable? So ensuring that we had to train them on how they can make local ORS solutions actually to treat diarrhea when they found it among the children. And then one of the things too we did too was strengthening reporting of diarrhea, which we achieved, and also inclusion of zinc and LORS in the essential drug list. And then there was donations of zinc and LORS to the DRF scheme in the state. So it was a very wonderful project, which I am still very proud of. And then also the level of engagement that we had, engaging with communities, engaging with community pharmacists, training we trained about over 1,000 community pharmacists, because the community pharmacists are the guys that give services, they're the ones that dispense drugs. So even if a doctor, or maybe even if a nurse, maybe whoever was attending to a patient, gives this as maybe a drug that should be given, they were trained to ensure that zinc and LORS was first given before any other drug. So it was just wonderful, and it gained a lot of acceptance. And I think that when we're doing some dissemination, the feedbacks we got too, from the community members, even from the DRF scheme, was really wonderful. And one thing I still really remember, engaging with the state DRF committee, was something that one of the directors said. He said something. He was that he's doing this. I'm gonna say it actually in house. I say I'm so good at Navy, and then also Absorbed and Yara. So it means like because of God and because of their children. So like they were considering. So they really wanted to do it, right? So they really wanted to ensure that, oh, even if things don't work well in their time, it's going to work well like for their children, but like for posterity sake. So the communities most times always want things to be better for them, and and as a project, and as as a funder, or maybe as one that wants to implement the project or wants to do something big, it's always just good to just hear from them, like engage them to see like their perspective. And I can tell you that these guys, like, they gave us like maximum support, like in ensuring that this thing worked, and I'm still so happy like with how that particular project went. Well, that's gonna be it on my experiences so far. And then I'll just do a quick conclusion. So final thought on this community engagement, like I mentioned, fosters participation, inclusion, trust, insight, because you're going to get insight from the community. You better understand how best to implement projects, sustain actions and solution. However, I had to also state that there are certain constraints, because even as we mentioned that all of this, like I mentioned earlier, there's a high probability that it will work. There are times that it doesn't work. Like, even no matter how like you even implement engage the community, because sometimes they could have like differing opinions. They could always like they could even be disputes, you get, and then people could have like different interests even in the communities. So those things are there, and these are things that may actually make a community engagement not to work. However, community engagement is strongly encouraged for any policy intervention program, and I would say it's a must. And building and working with the community is very effective. It's a very effective strategy, and it's one that anyone should do and ensure any process or any timeline of a particular project. And yeah, so that's in conclusion. And then these are just my references for putting this together. And then at this moment, I will retire. So if you have any questions, you can ask. I think I've even gone beyond 45 minutes. But anyways, thank you so much for the opportunity. And yeah, I'm open to questions now. Thank you.
Okay, thank you very much, sir. Thank you, thank you, thank you. I've really, really learned a lot, and I know that many of us here have learned one or two things. So we'll be taking questions now. Um, in the next 10 minutes, we'll be taking questions. So if you have any question to ask our guest facilitator, please just indicate by raising your hand, or you can type in your question in the chat box. Okay. Um, so you can ask your question. Joshua, so
Sorry,
you
is
raised your
anyone
hand.
asking a question?
No, sorry, I didn't raise up my hand. It was just
Okay.
Okay.
yeah.
Any questions?
So can I just assume I did very well, or it was effectively delivered?
Yes, you did actually.
Okay, or okay, so maybe like if there's no question, I don't know, like if someone could like, okay, I think there's like a question here. Okay,
Okay,
from
yes.
okay, so are there barriers in reaching out to community members, workers, and how can we overcome these barriers? Yes, I would say yes. That there are certainly barriers. But like what worked for us, like in the project that we were part of, that I okay, now let me talk like for myself. I was part of, anyways, working with the Kano State Ministry of Health, like in Nigeria. Well, there's already those structures, like the structures already exist, right? Like with like communities, community workers already. And then it was not just a Now I even forgot to mention. So it was not just the Ministry of Health. We also worked with the Primary Healthcare Development Agency, because those are the guys that are like much more involved with community workers, right? So, but we had like the support of like the like the executives, right? So with that, I think like it really made our work like really easy. And then the project I mentioned, the project on zinc and LORS, it was just really wonderful, because I think at the time we also had like a consultant anyways, like who was he worked with the Primary Healthcare Development Agency. So we had like that insider, who actually helped us. And then he had like some access to like, some people in like the communities. And then because basically in the north of Nigeria, I would say like these structures are actually always there. Like they have these structures. And it was just good for us anyways. And then like working with like the Hishba board, like in Kano, it really helped us. But other projects I've implemented, I think like we had like challenges. I think like coming to talk about like maybe the looping 3 projects that we worked with, it was quite difficult, like getting across, and then understanding that it is a very sensitive disease, or sensitive area to work. So I think we actually had a lot. I'm going to say a lot of issues, but one thing that helped us was this. So as part of our team, right, like the people we worked with, right, like my co-workers, and then also part of the community members are like the community volunteers or community case management workers. Many of them were actually people living with HIV and AIDS. So that was just the in route we could get, because if I'm coming to you and then you see like, oh, okay, like this is this, right? Like I'm also like you. I think like they really understood that better, and then it was better for us to have those engagement with them. But I think because for me, like, or maybe for someone maybe like who doesn't have a disease, like let's even talk about it. Like let's say like like the case I talked about, dementia. If I have never had dementia before, and then like I don't know like what kind of feedback I'm going to give, but if I have someone like who have had like this experience, firsthand, it's better for me to trust that person and want to open up. And so sometimes like that actually happens, and like for us, like that was really what helped us, getting these feedbacks and also engaging with them, and just ensuring that, oh, adherence was better. Yeah, that worked. But and like I would say, but then also some people, in the community, it's still always difficult, like I said, people could have like differing interests anyway. Like some people could be important, but they might just have like different interests. Maybe they're not interested in what you want to do. That is where informal informal influencing, I wouldn't call it influencing anyways, but like where like you have to use like people who are close to them. I think like if you're like in policy work, like because there's some people that they might not even really give you time, like maybe like if you want to like propose something, but you just have to pass through people that they know, right, and then pass through them to get the information across to them, and then get them to do the things that you want them to do. So basically that's it. And then a message is asking, is community engagement same as community entry? Community entry is part of community engagement. Community engagement is the bigger picture. Community entry is just how do you get access? How do you get access to the community? More of like the gatekeeping process. So meaning that who are in charge of a community. Let's say if I want to, okay, for instance, I think I was speaking with a colleague. I wanted to do like a health needs assessment among people living with HIV and AIDS in like, I think it was in like Cross River State or thereabout. We had to go through, guess what we went through? We certainly had to go through they have this society, right? So like an association. So going through those people, because that is just community, that is community entry. So through them getting access to the people, right? Like or other members of that association. That alone is community entry. Community engagement is far broader than that, far bigger. It's the process of engaging them, having the involvement, having the talks, getting your data or whatever thing you're doing, implementing the project, all of that is part of community entry. So community engagement rather. So community engagement is a bigger picture. Community entry is just a part of community entry, of community engagement. I don't know if you actually understand that message. Okay, thank you. So any other question?
Um, I think I have a question on my end. Are there like specific digital tools or platforms that can help enhance community management? I mean, like technology, anything digital. Yeah.
Okay, well, so I think maybe you just have to like define the context, because the context is really what matters, the context of like the community, because communities to communities are different. It's definitely going to be different from like the way it's going to be like in the UK, certainly, because like let's say like the NHS, like for instance, like they have like a directory, of like people that access healthcare service, and they have that like on their like their health records, right? Like you can have that access to that data. But then they still have the problem of GDPR, like you know, the protection thing, that when it comes to like sharing data, but it's like they do have, like those resources. But like when it comes to like, Nigeria or maybe like other countries, like let's say in Africa, like where the community structure is different. In the UK, like when I was in the UK, there's something called NICE. So it's like this guys that are National Institute for something something. They're much more involved with like so if like there's a new drug, right, like that they want to introduce, let's say in the health system, or maybe a new intervention, they do always try to get feedback from the community. So like they engage communities, including like even we students at the time, to know, or like what are our feedback. So they do have like community consultations, right? I think like that's how they called it. And then you could like be a part of it. You could be like an observer, or you could just like contribute. You get like to it. So they have like in like in like HICs, like much more developed countries, they have like platforms like that where, oh, you can register, be like a member, choose to like join all of those things. They exist. But anyways, like I said, it depends on the context and then what you're working with, or the community too that you want to work with. Yeah.
All right. Thank you very much. I got what I wanted from that. Thank you very, very much. Someone is asking if you'll be able to share the slides.
Definitely, yes. I will share it with Equicare Strategies, and
All right.
then we can forward it. Yeah, I feel like you have like the emails of everyone. You can certainly share the slides, of course.
Yes. Thank you very, very
Definitely,
much.
yes, yes. So I'm just gonna let me just send it right now via email, so you can just have access to it, and then maybe when you're sending the next email out, you can then
All
attach it
right.
up. Right.
Thank you very much. Thank you. Thank you. The
Okie doke.
session was beautiful. Thank you. Okay.
I'm also sorry that I took much more longer time, but anyways, it's good that at least I tried to explain everything.
Yeah, okay, sir. Thank you so much, sir, for the session. I hope all of you can hear me, right?
Clearly, clearly.
Okay, thank you
Yes,
very
we can.
much. It was very, very insightful. I it was especially when we started the case studies. It was so, so interesting. Like I didn't know whether we are supposed to keep on having more case studies. It was very, very interesting. So I like my eyes were open to a lot of things, and I really appreciate you for all the efforts and everything. Thank you so much. We hope to see you another time in our health policy forum, and thank you so much for the support and everything. And for everyone present here, I really appreciate you for taking the time to attend our health policy forum. This is the last for the year so far. We'll, we'll continue having more in the previous and in the next year, the new year. So thank you very much. Just as I stated earlier, you should stay put and stay updated in most of the activities that we keep on having for from now till next year. So thank you very much everyone for I know it's not easy to stay for 1 hour 30 minutes for a webinar, and most of you were very attentive and were listening all through. I really appreciate you for that. So if you can take a picture, I don't know if you can, all of you can open your cameras. I don't know if that will be possible so that we can take before we enter the meeting. So for concerning the slide, I'll share it to the group and I'll also share through email. So thank you very much. So I don't know if you can open your camera here. I can see one person, Adeze. I can see Matthew too. Another person. So I also share, and also if you have any further questions, I will share his email so that you can also contact him via email. So that if you have any follow up questions that you need to ask him. So I can see most of you. So I will take it in a minute. Yeah, I can see some other people. Oh, yeah, can I see some other? Okay, now I can see a lot of you. So I don't know whether I should say cheese or let's say community engagement. I don't know which other word should use. Oh, I didn't hear you.
You can just say health policies.
Okay, okay. Let's say health policy. Everyone, say health
I
policy.
don't know. You just don't want to say.
Okay, I've taken most of the pictures. So I think I've taken them all. So thank you everyone for coming. It's a pleasure having all of you here. So thank you so much. And I'd like to say good night to each and every one of us. The slides and some parts of it were recorded and we share it on YouTube for each and every one of us. So the slides will be shared. His email will also be shared if you have any follow up questions. So thank you everyone for coming. Have a good night rest. Thank you. Bye.